This session particularly, we are going to have eminent speakers, and the panel discussion is about collaboration. I mean, how to leverage technology in collaboration. See, basically, healthcare cannot function as a silo. We have found that, say, multiple agencies, let us government or private, or whether it is healthcare provider, health service provider, tech provider, so many people work together. And unless there is a collaborative effort, we have found that during COVID, a collaborative approach helped in reaching out to multiple patients in the crisis. So all these speakers will be speaking about how collaboration can be made effective leveraging technology. So the first speaker is Dr. Pramesh, is a well-known speaker as well as personality in healthcare. He's the founder of the National Cancer Grid. Dr. Pramesh is the director of Tata Memorial Hospital and the professor and head of Department of Thoracic Surgery at Tata Memorial Hospital. He's the convener of National Cancer Grid, imagine a large network of 170 centers across India, actually. Connecting all these things, collaborating all these people is the need of the hour because cancer delivery is not reaching out to many people in the tier 2 and tier 3 town. The mandate of the grid is, you all know that it's provide uniform standards of cancer care across the country. And he is committed to the efforts towards reducing inequalities in cancer care and making cancer accessible to the all geographic regions, whether it's north, south, or northeast, whatever it is. He's also visiting professor at the Division of Cancer Studies, King's College London, and the Institute of Cancer Policy, King Health Partners, London. Over to you, Dr. Pramesh.
Thank you. Thank you very much for that kind introduction, Mr. Selvaraj. I'd like to take this opportunity to thank Mr. Mittal for the opportunity to be part of this, what seems to be a fascinating meeting. Yeah. So speaking on leveraging technology for collaborations is something very different from what I've spoken on. And rather than look at solutions from a technology lens, what I'd like to do is to divide my talk into three parts. The first, which would be on the problems facing cancer care in India. And I think this is just likely to be an exemplar for all other health situations beyond cancer as well. And subsequently, I'll go on to the cancer grid itself and come to the final part, which is the technology part. And you'll find that much of this is interlinked with each other. So the reason we started this network is this fairly disturbing heat map that you can see of 75,000 patients with cancer who visited the Tata Memorial Hospital over a 3-month period. And most of you know that we are located in Mumbai here. And this density of patients that you see from the state of Maharashtra in and around the state is fairly understandable. So approximately 38% of our patients come from the state of Maharashtra. The corollary to that is that nearly 60% or more come from other parts of India and neighboring countries. And you see this very stark difference that you see in the north, the east, and the northeast India, and the density, which is much scarcer from South India and parts of Western India. And this clearly demonstrates the lack of access to care that these patients face. And just to give you context, it could take anywhere from 36 to 48 hours to travel from Naharlagun in Arunachal Pradesh to Mumbai. And add to this the costs of staying in an expensive city like Mumbai and accessing cancer care. Added to that is the fact that cancer incidence globally is increasing, but in India, it's increasing, and in many other low-middle income countries, it's increasing at a rate which is faster than in high-income countries. It's expected there's a 70% increase in cancer incidence in just under 2.5 decades. And this just adds to the total number of patients that we need to tackle. Added to this are the gross economic inequities that we have in access. And this is primarily because the overall healthcare expenditure is predominantly out of pocket. 70% plus is out of pocket personal expenses, whereas just 20% of healthcare expenditure is from public funds. And just to give you context, if you were to compare the UK to India, the UK spends 12.8% of its GDP, whereas India spends 1.5, and it's dropped to 1.3 this year. The per capita GDP in the UK is $40,000, whereas the per capita GDP in India is 1940. Without adjusting for purchasing power parity, what you're looking at is a 5,000 plus per person expenditure, public healthcare expenditure in the UK on health compared to $30 in India. And even if you were to adjust this for purchasing power parity, this $29 would merely go up to $125. So clearly, there's a lot that we need to catch up with as far as provision of public healthcare is concerned. This is an Ernst & Young report a few years back, which looked at certain surrogates of cancer facilities that are available. We looked at the linear accelerators, which are the radiation equipment, the dedicated cancer beds, comprehensive cancer centers, as well as the trained human resource to tackle cancer. And while the estimated requirements were X, the actual numbers that were available was 0.5X. And in certain cases, this was not even looking at the ideal situation, which you see on the third column, but at a more realistic expectation that would be required to treat the growing burden of cancer. And again, to give you context, we are sister institutions with the MD Anderson Cancer Center, which is the largest cancer center in the US. And we are remarkably similar in many ways. We see almost the same number of patients every year. And while the MD Anderson has 1,700 physicians, we just have 188. So we were faced with a problem which which required a fairly unconventional way of addressing this, and relying on the organic growth in the facilities that we would be able to provide by way of government increases in healthcare expenditure, increasing setup of government cancer centers was not something we could afford the luxury of, given the rapidly growing burden. So therefore, we came up with this solution called the National Cancer Grid about 10 years back, which was funded by the Government of India and is run through the Tata Memorial Center with a view to eliminate these disparities in cancer care. So currently, we are a network of over 270 cancer centers. We've expanded the scope to include research organizations, patient groups, professional societies across the country, which all work towards three major common goals, which are primarily the uniform standards of care, making it unnecessary for somebody from Arunachal Pradesh to travel to Mumbai for treatment. The second being developing trained human resource to adapt to the increasing requirement. And finally, to create a ready platform for collaborative multicentric cancer research. One of the first exercises that we did about 8 years back was to look at the growing burden of cancers, to quantify the burden, to identify national priorities and compare them with global research in cancer research. But most importantly, how could we deliver affordable and equitable cancer care in India? And we had some of the world's experts in global oncology contributing towards these three pieces. An early initiative that we started was to have uniform treatment guidelines. We had the first edition in 2017, and we deliberately made this very simple and easy to operate, because busy clinicians in the clinic in various district general hospitals and smaller hospitals would not have the luxury of being able to go through tomes of data to be able to get these guidelines. So these are all in algorithmic format. We also realized that India was as much a problem of overuse as underuse. So we had some of the centers overuse and waste resources. Therefore, we came up with a set of recommendations which were low value or harmful practices that should be avoided in cancer care. And subsequently, we got over 250 of India's top oncologists congregate and come up with resource stratified guidelines. So the resource stratified guidelines differ from the previous guidelines in the sense that this takes the cost effectiveness of an intervention into the equation. And as soon as these guidelines were launched, the then Deputy CEO of the National Health Authority immediately committed to connecting these to the Ayushman Bharat reimbursement. So automatically what happened was that the poorest 40% of India, which is covered by Ayushman Bharat, would necessarily need to be treated with evidence-based healthcare as opposed to what was happening before. And therefore, we built in a level of quality which was otherwise non-existent in the public healthcare system. Quality is central to everything that we do. This is one of our very low-tech initiators, which looks at a web-based system of quality assurance in pathology. There is an equivalent in America called the College of American Pathology accreditation, which is extremely effort-intensive, time-consuming, and very expensive, with the result that more than 95% of cancer centers in India do not go through the CAP accreditation. We go through it ourselves, and what we did was to create a leaner, meaner version of the CAP accreditation, which we offer on a web-based platform free of cost to any of the members who are part of the NCG, thereby bringing in quality into pathology diagnosis as well. We've expanded this to include molecular pathology and to include hospital improvement processes as well. So we run a process of training people on quality improvement, on how to run hospitals and make them more efficient. Leveraging technology again, we use a web-based platform where patients from anywhere across India can upload their reports, and this includes even sophisticated data like DICOM images and pathology images onto a secure website. And the backend of this system called Navya puts it into a structured format, sends it to an expert within the National Cancer Grid, who then feedback the opinion, all happening in a median turnaround time of under 24 hours. So this has democratized the way cancer care is accessible. So a patient who wants an expert opinion from Arunachal Pradesh does no longer have to travel to Vellore or Delhi or Chennai or Mumbai for the expert opinion. All they need to do is do this on a web-based platform. Multidisciplinary care is central to cancer care. Outcomes are superior if you have the opinions of a surgeon, a radiation oncologist, a medical oncologist, a pathologist, and a radiologist. But some of the smaller cancer centers, which are part of the NCG, do not have the bandwidth to be able to do this, and hence do not have a tumor board. So what we did was to create a virtual equivalent of the tumor board, and we did this much before COVID struck us. We started this in 2016, and to date, over 800 virtual tumor boards have been held, with more than 4,000 patients having been discussed. And though this was initially meant to be a patient-centric, patient-focused initiative, an unanticipated benefit was the fact that this also started educating and training some of the smaller oncologists in the smaller centers on how to deal with complex situations in cancer. Leveraging the fact that we are a very large group, we have been able to negotiate with journal publishers and get subscriptions for journals at a fraction of the cost that an individual center would have to pay. So a typical center would just need to pay 10% of a journal cost to be able to access some of the most leading journals in cancer. We also aggregated the library holdings of all our NCG members, and through a discovery tool which we developed and runs on a web-based platform, we're able to share these resources in a centrally indexed manner across the members of the NCG, again democratizing cancer education within the NCG members. We also have a massive open online course under the banner of ncgeducation.in. Several courses run on this platform, which it's not nearly on the scale of edX or Coursera, but in its own way does a lot to improve the access to cutting-edge advances in cancer and the newer developments that we see with cancer through a web-based portal. I did mention to you the challenges of traveling from the Northeast to main cities, and this doesn't apply only to patients. It also applies to cancer professionals, with the result that continuing medical education here is a challenge, and very few oncologists from these states actually visit or participate in conferences in cities like Mumbai, Delhi, Chennai, and therefore they lack what the recent advances are. So what we did was to completely flip the system around. Instead of expecting them to visit these centers, we sent a group of experts from the NCG to conduct training workshops in this. And what we did was to run a series of workshops in two cycles, wherein we covered 11 cities across the length and breadth of the Northeast, wherein we were able to train hundreds of pathologists on what was quality reporting in pathology. And based on this, we had requests from other states, including Andhra Pradesh, Karnataka, states which you would traditionally consider as not having challenges with access. So even in these states, it does look like bringing medical education to the doorsteps does have a role. Going by our success with the negotiation for journals, we started doing this for cancer drugs as well. So what we did was to aggregate demand and pool the volumes from the NCG centers, thereby bringing in a larger volume for negotiation. We followed a central tendering and negotiation process. We had several surrogates for quality of the drug as well as the pharmaceutical company which supplied them. But the final contracts after negotiations were signed between the pharma companies and the individual centers. And we've been able to get discounts ranging anywhere from a minimum of 20% to a maximum of 95% on MRP. And the average discount that we were able to get here was in excess of 75%. So what we've done here is to reduce the overall costs of cancer medications at least to 1/4 of what it would have been if the centers were to go for negotiations themselves. We started working on patient health records and the ability to share patient health records very early. In 2017, we had a hackathon in Bangalore where we got some of the best brains in IT to brainstorm with us on how we could make patient health records more accessible, how we could enable patients to own their own health records, and with their consent, share it with other healthcare providers whom they would be consulting subsequently. And I'm happy to say that this initial very small project, which was a proof of concept that we established, went on to become the heart of what the National Digital Health Mission launched by the NHA was, and it still remains a very important component of the ABDM. Research is fundamental to everything that we do. As I mentioned, we do fund cancer research. I'll not go too much into details for paucity of time. We enable researchers who are busy clinicians with the nuts and bolts of doing studies by having a clinical trials unit and an academic contract research organization. We do workshops on training individuals on how to do research, something which is lacking in undergraduate and postgraduate medical education. A lot of this is run on a blended learning module, part of it being online and part of it in an in-person workshop. We believe very strongly in collaborations, which is the theme of the session. We work closely with the DBT. We signed an MOU with them on cooperation in cancer research. We signed an MOU with the Ayushman Bharat, working on package rates and linking quality to the care that is provided under the Ayushman Bharat. As I mentioned, cancer treatment reimbursements under the scheme are made only if clinicians and hospitals adhere to the guidelines that are part of the National Cancer Grid. Going by the success of the Cancer Grid in India, we've been approached by several other low-middle income countries. So we launched the Center for Global Health under the National Cancer Grid, which has had encouraging response from several low-middle income countries and hospitals from across the world. Our most recent effort has been to create a Center for Digital Oncology. And this was mainly with an effort to centralize our efforts to adopt and promote digital tools and technology for cancer care in India. And the model is that we'll have an advisory board, the Center for Digital Oncology, working very closely with the NCG centers to work on supporting them in their technology initiatives, to drive some common initiatives, for example, interoperability, and for research on diagnostics and care pathways. And Koita Foundation has committed support for the NCG Center for Digital Oncology for the next 5 years. We very recently signed the MOU for that. The main the purpose of creating this was to have several projects which will include the following, but not limited to them. Unifying electronic medical records, need of the hour, given that 2/3 of healthcare providers currently in India do not have electronic records. Synoptic reporting formats, which will bring in uniformity, quality, as well as interoperability of data. Interoperability between varying electronic medical records, seamless exchange of patient health records, digitization of treatment protocols. So currently what the Ayushman Bharat does is manually approve these claims. What we're trying to do is to see if we can digitize these, linking them to the guidelines. And finally, a very ambitious project on machine learning and artificial intelligence to augment diagnostics and patient care pathways. Our future steps include integrated data collection and aggregation, creation of a rare cancer and exceptional responder registry. We'll extend the group negotiation in drugs to equipment and other consumables as well. And finally, to get to a health technology assessment platform. An effort of this nature would not have been possible without the support of several organizations which have been unstinting in their support to us, several national as well as international, government as well as private and philanthropic organizations. And I'd like to take this opportunity to thank them all for their support. And this is the current map of the NCG, which, as you can see, spans the length and breadth of the country. So happy to take any questions. Thank you.
Thank you, Dr. Pramesh. That's an amazing presentation. I think, say, your theme of democratizing the resources by collaborating helps in reducing the cost by means of various means, and also spreading the education to various parts and making cancer treatment accessible to the remotest part of the country. Thank you. So once again, I thank all the speakers for the amazing presentations and sharing their experience in various fields they have been working. As a collaborative approach, all these knowledge can be pooled and democratized and used for ABDM or any future programs for the public health. And I thank Kaho and Dr. Vijay Agarwal and Lalu for giving this opportunity.